Chapter 16, Building Learning Around Clinical Problems and Presentations. A clinical problem or task undertaken by a healthcare professional can serve as the basis for learning. The student is motivated by the more authentic learning experience. The importance of the clinical problem in student learning. In the traditional curriculum, learners start with a consideration of basic and clinical sciences, then move on to the application of the theory to practice. They first learn, for example, about thyroid physiology and the hormones secreted by the gland and about the pathology of abnormalities associated with the thyroid gland. They then move on to see patients who present with a goiter or with the symptoms of underactivity or overactivity of the gland. In contrast with an integrated and problem-based approach, students start by considering patients with a thyroid problem. They have then to work out what knowledge and skills they require to assess and manage the problem. Clinical problems can be used not only as the starting point for the students learning in one topic, but also, as in problem-based learning, a framework for the learning. In Dundee Medical School, the curriculum from year 1 to 5 was structured around 104 clinical presenting problems, such as abdominal pain. Structuring learning using clinical scenarios as a framework offers a number of advantages. It motivates students to understand the relevance to clinical practice of what they are learning. Relevance is part of the FAIR model as described in Chapter 3. It introduces the student to clinical practice and helps to establish their personal identity as a doctor. It provides a basis or framework for lifelong learning. It facilitates future knowledge retrieval as the situation where the knowledge is learned more closely resembles the context where it is later applied. Problem-based learning. What is PBL? Problem-based learning has been adopted worldwide as an education strategy in medical education. Its use, however, has not been without controversy. The principal idea behind PBL, as described above, is that the starting point for the learning is a clinical problem. This is the focus for the student's learning and drives the learning activities on a need-to-know basis. PBL has made a major contribution to medical education, but there has been a lack of clarity or a conceptual fog surrounding what is meant by the term and how it is implemented in practice. The underpinning educational principles are: students are presented with examples from clinical practice and then work out the principles or rules from the basic and clinical sciences that allow them to understand and interpret the problem. Students engage actively with learning, collaborating with their colleagues in a small group. Students learn by self-study, thus ensuring they understand the subject matter. For PBL to succeed, it is essential that both students and faculty are motivated, have an understanding of these principles, and accept their roles and responsibilities. In PBL, approaches have varied regarding the steps in the process, the nature and format of the problem, and the level of support given to students. PBL is based usually on small group work with 8-10 students per group, although larger numbers of students can be engaged. A member of staff usually facilitates the group, but students can act as facilitators. Although small group work is seen by some as an essential feature of PBL, the technique can be used in the lecture situation or with individual students working independently online. PBL can be implemented in practice in a variety of ways. Here is one example. The sequence is normally completed over the course of a week. 1. At the first meeting of the group, students receive the problem scenario. Traditionally, this has been in print format, typically a short description of a patient's presentation. The problem may be presented, however, using a multimedia approach with a computer, videotape, or simulator. Simulated patients have also been used. Students identify and clarify unfamiliar terms, then define and agree the issues to be discussed. It is important that students do not spend too much time figuring out what they should learn at the expense of time spent learning. Students consider possible explanations of the situation presented on the basis of their prior knowledge and identify areas where further learning is required. The tutor helps to ensure that the learning outcomes identified by the students are appropriate and match the learning outcomes for the course and are achievable in the time available. Students then work independently and gather information relating to the learning outcomes. The group may agree to subdivide the task and allocate different responsibilities to individual members. Some of this work may be done in the small group setting online using a search engine such as Google. 3. The group reconvenes and shares the results of their private study. What they learned is then applied to the problem presented. So, additional information about the patient may be presented to the students, and the above process is repeated. The PBL continuum. Various points have been defined on the continuum between a problem-based approach and an information-oriented approach as described in the SPICES model. This is summarized in Appendix 5. The context for PBL. PBL is usually adopted in the context of an integrated medical curriculum, but the strategy can also be used in a curriculum where the emphasis is on subjects or disciplines. Most commonly, PBL has been used in the context of the early years of undergraduate education. The strategy has a role to play also in the later years of undergraduate education and in postgraduate and continuing education, although a task-based approach, as described later in this chapter, may be more appropriate in these settings. In continuing education, the doctor may work individually at a distance with problems presented online or paper-based. PBL can also be used alongside team-based learning, as noted in Chapter 24. Task-based learning. What is task-based learning? Task-based learning has been described by Phil Race as a very useful approach to integration of the medical curriculum and, not least, a time-efficient and cost-effective approach to developing highly relevant skills, attributes, and competences for the profession. Task-based learning incorporates the same educational philosophy as PBL and indeed has been described as part of the PBL continuum. In task-based learning, the focus for the learner is not a paper problem simulation, but a description of a task addressed by healthcare professionals. An example is a patient with abdominal pain or a patient with breathlessness. In task-based learning, the objective is not only to learn to manage a patient with the problem, but to gain a more in-depth understanding of the task or problem by learning the basic and clinical sciences relevant to the problem. In the abdominal pain example, in the early years, the student's attention is focused on issues such as the relevant anatomy and physiology of the abdomen, on the understanding of the mechanism of pain and on abdominal pathologies, and in the later years on the different approaches to investigation and management of a patient with abdominal pain. Figure 16.1 in task-based learning, learning occurs around the task. Management of patient with abdominal pain, learning about abdominal pain. History taking and examination, investigations, management. Generic competencies, pain relief, patient education, indications for referral, in-depth understanding of basic and clinical sciences related to abdominal pain. CKBL in a clinical setting. CKBL is useful as an approach to deliver curriculum integration and PBL in the context of the clinical clerkships. In the example of abdominal pain, students concentrate on different aspects of the task in each of their clerkships, and a wide range of learning outcomes or competencies can be addressed, such as acute abdominal pain and the emergency diagnosis and management in a surgical clerkship, approaches to the investigation of a patient in a medical clerkship, specific aspects relating to gynecological causes in a gynecological clerkship, age-related differences in a geriatric or pediatric attachment, psychosomatic aspects in a psychiatry attachment, the roles of different members of the healthcare team, early diagnosis, decision making, and coping with uncertainty in a general practice attachment. When, for example, should a patient complaining of abdominal pain be investigated and referred to hospital? Geographical and cultural differences in an overseas elective. CKBL places more responsibility on the student and serves to integrate learning across a range of clinical locations in an undergraduate curriculum or postgraduate training program. Implementation of TKBL. Medical schools that adopt a TKBL approach generate usually about 100 to 150 clinical presentations as the focus or framework for the curriculum. The student's understanding of the task becomes more sophisticated as he or she progresses through the curriculum. A list of the 104 presentations adopted in Dundee Medical School is given in Appendix 6. Rubrics or blueprints should be produced that identify how each task contributes to the learning outcomes and to the range of learning experiences in which the students engage. As described above, each clinical clerkship can contribute in a different way to the student's mastery of the learning outcomes of the course. CKBL provides a structure and focus for postgraduate education that previously was all too often lacking. It helps resolve what may be perceived to be a conflict between service delivery and the education of the student or trainee. 6 tasks performed routinely by trainee dentists were identified as the basis for a postgraduate dental training program. The expected learning outcomes were specified for each task, as illustrated in the grid in Appendix 7. The tasks specified in the curriculum documents also provide a framework for a student's portfolio and can be used to assess their progress, as described in Chapter 33, Clinical Presentations. A similar approach to task-based learning is the clinical presentation curriculum introduced in Calgary, Canada, which is based on the problems patients present to doctors. Clinical presentations were defined that represented a common or important way in which a patient, group of patients, community or population actually presents to the physician and which a graduate would be expected to deal with. The presentation identified also has to be important and substantive enough to cover a broad content so that the learning outcomes can be met. Less substantive clinical presentations were included under a broader category. For example, epistaxis was included under breeding tendency bruising. Both a clinical presentation curriculum and task-based learning offer students the benefit of an organizational scheme that serves as a scaffold to which they can add new information and which relates theory to practice. A curriculum cube. As discussed in Chapter 12, a curriculum is much more than a collection of topics to be studied or a syllabus to be followed. Brad described in the cubic curriculum three curriculum dimensions: the subject matter, cross-curricular themes and issues, and the different methods of teaching and learning. In medical education, this translates into the three dimensions of the learning outcomes or competencies, the clinical presentations and tasks, the courses and the learning opportunities, e.g., a lecture or PBL session. Figure 16.2, the curriculum cube. The clinical presentations and tasks are related to the learning outcomes and the learning opportunities. Clinical presentations and tasks, learning outcomes, learning opportunities. Each clinical presentation or task is related in the curriculum cube to the relevant learning outcomes and learning opportunities. Each learning outcome is related to the clinical presentations that contribute to the mastery of the learning outcome and the courses and learning opportunities where it is addressed.